Well, good morning, everyone. I'm doing the introduction, I'll just start off with advising everyone that in June 2015, the Health Department had an internal review with regard to all of its programmes, and one of the outcomes of this was how to better utilise case management programme. It was decided that case management programme should move to a model of care that is better integrated with clinical services. Meetings with tertiary hospitals, HIV teams, and also stakeholders, and relocation of case management programme to RPH. CMP to be developed into an evidence-based integrated case programme with different databases such as Ultra. CMP more effectively addresses clients with complex psychosocial needs while still retaining statutory functions. An agreement between CDCD and West Australian Country Health Services that CDCD and CMP continue to support HIV-positive high-risk clients in the regions. CMP Programme Draft Guidelines 2012 are at present under review and out for consultation. New Draft Guidelines 2016 includes moving toward an integrated case management model. Traditionally, CMP has only investigated formal allegations. Recent complex case, HIV-positive Aboriginal client who was itinerant in Perth, exemplified a gap in health services. This person was not on treatment, and lifestyle factors meant the client was high risk for transmission of virus to others. As a result of this case, scope of CMP to include those who are potentially placing others at risk of HIV by virtue of their life circumstances and also the high itinerant nature and of locating them. The new model is complementary but does not replace services offered by SHAPE, which is provided by West Australian AIDS Council. That is very important. SHAPE deal with voluntary clients, CMP deal with involuntary clients. So this is a very important aspect. Also, CMP has now moved under the umbrella of STI and BBVs. Lisa Bastian being our new manager, myself, case management officer, and a new acting case management officer, Ines Bruce. So that is a new shape of things to come. And I would now like to introduce Alison Kane, clinical nurse specialist at immunology, we will discuss further the outcomes of this new merge. Thank you very much.
Thanks, Bernadette, and good morning to you all, and good morning to my colleagues out there in the regions. Most of you know me. Where are we? Let's get the buttons right. Trust me to get the buttons wrong. So I'd like to really present two case studies as outcomes of some of the work that we did this year with Case Management Programme at Royal Perth. There was a total of 7 high-risk cases that we identified and referred for a pilot trial. All these cases had intensive nursing, social work, medical and case management support. Of those 7 cases, 2 were SHAPE clients from the West Australian AIDS Council. So the first case I'm going to attempt to present, you've heard of the race that stops the nation. This was actually a case that challenged our health services. This was a homeless Aboriginal woman who was currently in a refuge at the time and was diagnosed in 2015 as part of opt-out testing, a pilot study by the Mobile GP Service. The Mobile GP Service called immunology at Royal Perth and spoke to our nurse practitioner, and we sought special permission to get our nurse practitioner out into the community to deliver that diagnosis with the GP and support the client. Follow-up appointments for this client were made at Royal Perth Hospital, and she did opportunistically turn up in our department where I actually saw her. That first meeting was probably really, really important because that was the meeting where we were able to establish a rapport and relationship with the client. I couldn't go into all of the education. We all try and follow our processes about education, rights and responsibilities. But what I was able to identify was the lady's family, where she was from and where she'd travelled through. So that was 3 different regions and also living in Perth. So of course my alarm bell started to ring. She did follow up a few weeks later. She turned up again. She didn't turn up to any of the appointments we made, but she did turn up and we walked her over for a clinic visit. She did not wait to see the doctor, however she did engage with social work and nursing team. We lost her. Of course she was homeless, we had no way of finding her. 20 attempts plus were made to try and find this lady. We were at a loss, and this is really quite hard for us in metropolitan Perth to find clients. When I did interview her in the department, I was able to actually find out maybe where she hung out, which area she hung out with. So basically, the following stage was that she was then identified as a contact of new diagnosis and outbreak in a particular region. So this declared what we called at the time a public health emergency. How are we going to find this client? How are we going to deal with this client? So we had many phone calls, many teleconferences, and we did identify at this point this wasn't the only case like this. There were many cases like this out there in the regions, and there were many cases like this in metropolitan Perth. So we did a bit of a drive round, and because I'd seen her and obviously my colleague Leah had seen her, and we went out with case management. We had to get special permission to do that and redeploy resource a little bit. We couldn't find her because it was like looking for a needle in a haystack. Us cruising around parks is probably not a good look either. So we put an alert in our emergency department, and I also called her medical record file to our office. And bingo, they called for her note. So I was able to break the Olympic record of getting from immunology across to emergency, where I was actually able to see the client, review the client, and also call on our amazing social work service to support, because this time the client had actually got Homes West Housing. We had an address, so we actually had something to work with, which was fantastic. We were then able to link in. She did discharge against medical advice, so we lost our opportunity, but we had that address. So thanks to the efforts of case management program, and again, seeking special permission from Royal Perth Hospital to leave the joint, to go out and find the patient and visit the patient at home. We made several attempts to try and get her to come back in. This didn't work, and then on one attempt, we did go out there. She was really, really sick, and I was quite worried about her health. She was broken ankles, covered in abscesses, and her viral load at the time was over 1 million, and her T-cell count was just over 100. So what happened was I was sitting at my desk, and all of a sudden people came rushing for our resus trolley that sits behind us. So I just carried on working as I do, sending my emails out to the regions. And then I got a phone call, your patient's in ED. There's just been an emergency call. She collapsed outside immunology. So she actually had come in to find us. And from that presentation, we actually admitted her under immunology up on 10C, where we were going to sort of initiate therapy and provide full supports. At the time, her partner was also admitted on another ward. So what we did, thanks to our amazing social worker Morgan, we developed the honeymoon suite on Ward 10C, where we put them both together. We were able to give her the support to disclose to her partner and get her partner tested. Unfortunately, he was negative. So from there on in, to cut a very, very long story short, we started weekly visits, daily phone calls, fortnightly visits. The case management program, go out and get her, bring her into the immunology department, where I support her medication adherence through Josette box filling. What we have achieved is we've had an amazing improvement in her chronic health conditions. Her diabetes is under control. We've ceased her blood pressure medication. We've had amazing contact with service, even though we do lose her at times. The viral load, we all want that undetectable. We haven't achieved that there, and I know teleconference after teleconference, that's our gold standard. We want this viral load undetectable. We will get there. We're not going to give up, but I think it's a real credit to what's happened with the teams and bringing her in. Also, she's going to be a long-term client. Transition, discharging of this client really is probably not going to happen. So that's our first client. The second client, and I want to make sure you're all awake, because I've put in male MSM. Well, of course that is, isn't it? So diagnosed in 2012. I read that last night and I went, oh, you're going to pull me on that. This client was diagnosed 2012, had a non-attendance at the outpatient clinic all through 2013. However, what there was a rapport and a relationship with a particular nurse in our department all through that year. So all through that year, that nurse was trying to engage this client. He had a fear of attending the clinic, a fear around the diagnosis, a fear around accepting diagnosis, and they were the reasons why he wasn't attending. So, for about a year, it took that nurse to persuade him to come. He came to the clinic in 2014, commenced therapy on a co-formulated regimen, and rapidly got the viral load down to less than 40. 2015, he was named as a contact of a newly diagnosed patient. This client denied that he had HIV to his long-term partner, and also there were phone calls about was co-formulated regimen used for PrEP or PEP. So there was a lot going on behind the scenes. Further allegations were made about this client. So it was really hard because we like to be good cop and we don't want to be bad cop as part of clinical service, but we had no choice but to refer this client to case management program. He was also very active on all the MSM sites as well. So 2015 letters were sent out, visits by case management team, but they didn't really have any luck with this client at all in getting him to come in with service. And we were quite worried, obviously, about the ongoing risk of transmission to others. So due to that lack of engagement and response, the case management program sent out the official letter from the Executive Director of Public Health, which was hand-delivered. The client attended within the week. The integrated care and case management program plan was put in place, which Bernadette described to you. And what I'd like to say out of this was that this client has now attended all the appointments. He's got a lot of support in place. Part of that program is that he takes his treatment, he attends his appointments and gets that undetectable viral load. But also what's happened out of this case is he's actually developed a really special relationship, not only with our service, but with the ladies at Case Management Program. So to conclude, and most of you hear my talks and I go on about this at every talk I do, it comes down to the 2 R's. The rapport and the relationship you have with that patient. You've got to have that to get that client to feel that and build that trust in you, to get them to attend the service. If you don't have that, you won't get that information. And the first client that we discussed, if I hadn't have got that information, we couldn't have put the regions on alert to do the contact tracing. I'd like to add a 3rd R into that. This is the only time I'm going to ask you to speak till Leah's spoken. Anyone want to have a guess what that 3rd R could be? Resource. And we're going to come back to that at the end of the presentations. The 2 C's, the collaboration and communication that we have with our colleagues, we have with each other, the services that are here in Western Australia, not only the metropolitan ones but the rural ones. If we have that, we will improve the care that we provide. So finally, I would like to acknowledge, and there, how long have I got? Because I would like to make these acknowledgements if I make 2 minutes. So the immunology team at Royal Perth Hospital, Leah Williams, Morgan Bonnet, Mina John, David Noland, Laura, Ann and Jenny, that really support our service and allow these clients to turn up without appointments so that we can keep them engaged and support them. My dear mates at Fiona Stanley, Jacqueline Kerr, Sam Libertino. The case management program, their enthusiasm and passion this year has just been amazing. So Bernadette and Ines, I'd like to thank you. The amazing support we've had from Lisa, from STI and BBV program. Our colleagues at WAC and the SHAPE program, Beck and Daniel, thank you for all your support. And my dear mates out there in the regions, coming down from Kimberley and KPHU, Jeanette Ward, Katie, Ash, particularly Jules, Jahari and Troy, who have put in an amazing effort up there. We move across to Pilbara and Heather and her team up there, Philippa Jones, Tina Chernery. That case I presented, they've got cases like this all around up there. The Midwest, Moira and Lynn and Gloria, all the amazing work they've done for many years in supporting clients like this. And of course, my dear friends out in the goldfields again, to Claire and Jane and Hannah for all the hard work they do in keeping these clients engaged with care and having the amazing results that we have. We've actually got, for the regional clients, a 98% contact with service with over 90% undetectable viral load. The Aboriginal clients that we reviewed, we were 50% with an undetectable viral load. We're now 71% that are having an undetectable viral load. So thank you guys for your attention this morning, and I'd like to hand over to Leah